Good afternoon and welcome everyone. My name is Barbara Cochran. I'm the director of the DeTournier Center for Healthy Aging here in the School of Nursing, and I'm also associate director for the Northwest Geriatrics Workforce Enhancement Center, which is sponsoring this lecture series that's focused on Alzheimer's disease and related dementia. Today, I'm very pleased to introduce Dr. Ali Samii. He is a UW professor of neurology and co-director of the Movement Disorder Fellowship. He splits his time between the University of Washington and the Seattle VA Medical Centers. His clinical interests include the management of movement disorders such as Parkinson's disease, Huntington disease, tremor, dystonia, deep brain stimulation programming, and botulinum toxin injections. His research interests include deep brain stimulation, observational imaging and therapeutic studies for Huntington disease, genetic studies for Parkinson's disease, and epidemiological studies involving neurodegenerative disorders. And today he's going to be talking with us about a very important topic, treatment of Parkinson's disease, lessons that he's learned from cases. So welcome.
Thank you. So do I need to scream as loudly as you were just doing,
No,
or am I audible
those
with
mics
the...
are pointed at you, so I was
Okay,
trying to...
good. Well, I'm wearing one right now.
Yeah.
So hopefully I can be easily heard.
I tend to scream too loud.
Okay. And how do I get the cursor to go down?
Click, and the cursor will...
I see that...
Are you wanting to move this?
Well, I want to move away from my first slide and then move on to the next one.
Yeah, so it's
How do I
actually,
do that?
just these
Oh,
right here.
so I did that, it didn't go.
Interesting.
I moved it down, it didn't go.
All right.
No.
Help.
Usually we don't need help this early.
Yeah.
So if you want,
Okay, I see.
once
Okay,
you
good.
press it, you can use the arrow keys.
Sorry, another IQ failure here on my part. I should have just clicked on these little cursors. Okay, so to the next one. I'm going to talk about treatment mostly, but I'll say a few words and spend a few minutes going over some of the background on Parkinson's and what it's like. So in terms of prevalence, about most of the data from North America and Northern and Western Europe points towards the prevalence of Parkinson's being in the order of 3 per thousand, which is 0.3% in North America. That means about 500,000 to 1 million people would have Parkinson's disease, and 1% over the age of 60 have this problem. And that's probably for Parkinsonism rather than Parkinson's disease. And I can go over the difference between the two to some degree. The ratio of men to women being affected is about 1.2 to 1. So men are a bit more affected than women, but not by a huge margin. And the mean age of onset is around 56, 58, 60, late 50s. And we define young onset Parkinson's as Parkinson's, the motor symptoms of which begin before the age of 50. Very young onset would be before the age of 40, which is around 3%. Young onset, about 10% of folks with Parkinson's have onset before the age of 50. And about, I would say, 0.2, 0.3 to 5% before the age of 25 or 20. So we're talking like juvenile onset or very, very young onset. But those are rare. Those tend to be genetic. So the cardinal signs, the things you look for are asymmetric resting tremor, asymmetric rigidity, and asymmetric slowness of movement. And if you have two of those three things, you probably have Parkinson's disease. And then the postural instability part is sort of non-specific. It doesn't really show itself until later on in Parkinson's disease. So we rely on the first three. 2/3 of people with Parkinson's present with an asymmetric resting tremor. It can be dominant hand or non-dominant hand, a typical pair rolling type. So 1/3 of folks with Parkinson's do not have tremor, and they don't really get tremor later on in their disease either. So get used to that because you're not going to see tremor in everyone. Some of the non-motor features of Parkinson's disease, we rely on some of the other things that point toward Parkinson's disease. So loss of sense of smell can happen many, many years before you come down with the first tremor. The same thing is true for rapid eye movement sleep behavior disorder. Depression is common, and so is constipation. So of all the things I've listed here, the 4 things that are more commonly thought of as heralding signs of Parkinson's are REM behavior disorder, smell problems, depression, and constipation. Those are the big ones. And then obviously the sexual dysfunction, bladder urgency problems, anxiety, trouble with multitasking, and mild cognitive impairment, they're all part of having early Parkinson's disease. Restless legs is also one that I haven't listed here. So these are the criteria that my old boss, when I trained in Vancouver, came up with in the 1990s, and we've modified it a little bit in this paper we published 10, 12 years ago. So at the UW, the way we define Parkinson's at the clinical setting is having 2 of 3 things: resting tremor, rigidity, and bradykinesia, asymmetrically, and getting better with anti-Parkinson drugs. So if you have that set of criteria, then you have Parkinson's the way we know Parkinson's. But for definitive diagnosis, you need autopsy, you need brain tissue. But here is our working definition of Parkinson's at the clinical setting in case you want to enroll people in studies or have them undergo DBS surgery. As of 2011, we have the DAT scan available to us. We hardly ever use it because it's very tough to get it covered under insurance, which doesn't cover it. It can cost anywhere from $6,000 to $10,000 depending on whom you go to. But it basically has to do with looking at the dopamine pathway between substantia nigra and the striatum, which is the pathway involved in Parkinson's disease. And it's one of the markers for the dopamine transporter protein, which is diminished in Parkinson's. And you see in normality, you see a nice comma-shaped striatum, that's the caudate and the putamen on either side. And in Parkinson's disease, this is diminished, asymmetrically diminished. And usually the asymmetry you see on imaging corresponds to the asymmetry you see in the body. That is, if let's say the left body is more impaired, you would see more abnormality in the right side of the brain and vice versa. Doesn't happen all the time, but we do see the asymmetry. And the portion of the striatum, which is the putamen, goes bad first. So you see decline in this area, and then the caudate becomes abnormal next. It doesn't help you differentiate Parkinson's disease from other Parkinson lookalike syndromes like PSP or corticobasal syndrome, but it does help differentiate Parkinson's from normality, from normal aging, from essential tremor, which is the more commonly used scenario. Most of the time, as I said, we rely on putting people on carbidopa, levodopa to see if they get better with the medication, and then you diagnose Parkinson's. When do you start treatment? I normally start treatment when there is impairment of function, which can be very early in people. I also tend to lean towards starting relatively early rather than waiting until the patient is really, really impaired, because I'm one of the folks who believe that if you delay treatment, you may actually lose function that you may not otherwise regain when you start treatment too late in patients. So examples of what people come to you for because they can't do their ADLs, they can't do their job well, they have dystonia or stiffness that's too painful or uncomfortable. They have frozen joint syndrome, especially in their shoulder, which is one of the first joints that goes bad in Parkinson's because of rigidity in the shoulder, trouble with their walking and balance, and then if it's tremor predominant, the tremor gets in the way and it causes embarrassment when they're giving a talk in public or having dinner at the restaurant. So these are the reasons we start treating people. So this little schematic diagram goes through most of the drugs we use and where we use them and where these drugs work. So as you know, dopamine is a neurotransmitter in the brain. This is the presynaptic nerve terminal here from substantia nigra pars compacta. That's dopaminergic. This is the postsynaptic cell in the striatum, in the putamen, for example. And these are the little receptors to which dopamine binds and does what it does. And dopamine is exocytosed from these synaptic vesicles that contain it. As you know, levodopa is a precursor to dopamine. All it takes is just one enzyme, which is dopa decarboxylase, that makes levodopa into dopamine. But dopamine doesn't cross the blood-brain barrier. Levodopa itself does cross the blood-brain barrier. So it gets into the brain, and then it becomes dopamine by dopa decarboxylase, and the dopamine gets exocytosed into the synaptic cleft and binds to these receptors and helps patients move better. So that's how levodopa works. Carbidopa blocks the enzyme that makes dopamine from levodopa out in the periphery. Carbidopa does not cross the blood-brain barrier, so it allows more levodopa to get into the brain, to become levodopa, to become dopamine inside the brain where you want that reaction to happen. So it keeps levodopa from turning into dopamine in the serum, thereby allowing more levodopa to cross the blood-brain barrier. And when levodopa came along in 1961, it basically revolutionized the way we treat Parkinson's. And then when carbidopa came along in 1972, it helped us use a lot less levodopa dosage in order to get more across the blood-brain barrier. And the first thing that carbidopa did was it kept the levodopa from becoming dopamine in your serum, which causes nausea. This is a very nausea-producing substance in your serum, dopamine is, so it makes you puke and want to vomit. So that's why they call this combination cinnamon. Sin in Latin means without, emesis means nausea. So they call this combination carbidopa, levodopa without nausea, because that's the first thing it did. It helped reduce the nausea and vomiting from the levodopa compound. The other class of drugs I'll talk about are COMT inhibitors, entacapone being the most common one used, tolcapone being the next drug rarely used in this class of drugs. So what these drugs do is they make levodopa last longer. They block COMT, catecholomethyltransferase, which breaks down levodopa, thereby making it more available in the serum and making it last longer for folks who have end of dose wearing off. So that's the levodopa story. So this is the dopamine transporter that allows the reuptake of the dopamine back into the presynaptic nerve terminal so it can get recycled and put back into the vesicles. This is where the DaTscan ligand binds to, by the way. You saw the DaTscan, I told you it's a dopamine transporter scan. So the radioactive material used in that SPECT scan binds to this receptor, binds to this transporter here, and thereby looking at the dopamine population in the brain. That's how it works. So, and then agonists, these are synthetic molecules like pramipexole and ropinirole, which bind directly to the dopamine receptors postsynaptically and mimic the actions of dopamine. So you got levodopa, a precursor. You got drugs that enhance levodopa, like entacapone and tolcapone. You got drugs that mimic dopamine, like pramipexole and ropinirole. And you got finally the MAO-B inhibitors, which are selegiline and rasagiline, which do cross the blood-brain barrier, and they block the breakdown of dopamine itself. The dopamine you have endogenously from your own brain, and the dopamine you get from the levodopa becoming it in the brain. So MAO-B inhibitors, selegiline and rasagiline, they basically block the breakdown of dopamine, thereby making it more available. So now you have four classes of drugs. You got MAO-B inhibitors, you got the agonists, you got the levodopa formulation with carbidopa, and you got the COMT inhibitors. So these are the four main drugs we use for Parkinson's. So they're all in one way or another enhancing dopamine, mimicking it, or becoming it. So Sinemet comes in a whole bunch of doses. These are the doses that comes in regular release and the controlled release. Normally we use the 25-100 regular release or the 5200 controlled release. Those are the main two doses it comes in. The key thing is remembering that the levodopa in the ER version, in the extended release version, is 30% less well absorbed, thereby 30% less bioavailable to our brain. So when you convert someone from one to the other, you have to keep in mind to increase the dose a little bit for the ER and reduce it when you go back to regular release, so that you take into account that 30% difference in bioavailability and absorption. The problem with levodopa is that it's a very short half-life kind of drug. Once in your system, the half-life is just 90 minutes, so it doesn't last very long. In early Parkinson's disease, the ability of the brain cells to pick up levodopa, make it into dopamine, and store it in these vesicles is much better. So we have that buffering capability. So you can take the medication just 6 or 7 hours apart, and you can get away with that. In more advanced disease, there are those fewer levodopa-taking cells, uptaking cells. And so the pharmacodynamics of levodopa starts to mimic its pharmacokinetics. So you get shorter and shorter benefit from each dose. So you start taking your medication 4 times a day, 5 times a day, 6 times a day, 7 times a day, and even sometimes more frequently every 2 hours, every 90 minutes or so. The other problem is that it's the absorption of levodopa is in some people, highly influenced by protein. So if you take a big protein meal, the breakdown products of protein, i.e. amino acids, they compete with levodopa in crossing the gut into the blood and crossing the blood-brain barrier. So that's another area where you actually have trouble with levodopa's efficacy when it comes to taking it with food, especially meals that are protein-rich. So the problem, again, short half-life, so you get what we call endodose wearing off, trouble with protein limitation, and what we call dyskinesias. If you've seen Michael J. Fox fidgety with those involuntary choreatic movements on television, that's chorea. That's levodopa-induced dyskinesia, which looks like chorea. It's choreatic dyskinesia. So at high doses, even sometimes not so high doses, I should say, but most people eventually get some dyskinetic movements. It's mild now compared to, let's say, 20, 30 years ago, where that's all we had to use because we used so many other drugs besides levodopa. But levodopa is the most common cause of dyskinesia in people who take this medication. And let's say by the 5th year, almost half of the folks have some kind of dyskinesia. And after 10 years, 2/3 or 3/4 of the people have dyskinesia to some degree. It doesn't have to be severe. The most common one is head bobbing dyskinesia, where their head is kind of going like this, and they have trouble with maintaining the head still. But they can get dyskinesia in their trunk, in their limbs, and so on, and it can sometimes throw them off balance. Side effects include nausea. You can give them a little bit more carbidopa sometimes, beyond what the carbidopa they get already in carbidopa, levodopa. We can actually add additional carbidopa in the form of Lodocin. Dizziness and drop in blood pressure are side effects of levodopa. People with Parkinson already have dysautonomia. They're more prone to having low blood pressure. So giving them dopaminergic drugs like Sinemet or Agonists can plummet their blood pressure even more sometimes. And they do get drowsy from these drugs. They get less drowsy from Sinemet than they do with, let's say, dopamine agonists, but it does cause some drowsiness nevertheless. Something to keep in mind when you put people on it. COMT inhibitors are mostly used to alleviate end-of-dose wearing off. That is for people who feel like they want to take their medications more and more and more often with shorter interdose intervals. So this allows them not to do that. This allows them to take their medication, their Sinemet, still 4 or 5 times a day, and not have to take it 6 or 7 times a day by taking entacapone with each and every dose of their Sinemet. When they do that, it allows them to, it basically enhances the longevity of levodopa, so it lasts in the system a bit longer to alleviate endodose wearing off. Now, Stalevo is a relatively newer drug, which is a combination of carbidopa, levodopa, and entacapone all in one pill to just make it easier to take. And last but not least, tolcapone, which I hardly ever use anymore and hardly anyone uses anymore because it caused some liver problems and some fatal liver failure in people who were taking this. So now we have entacapone. We hardly ever use tolcapone for that reason, but it's a more potent drug than entacapone. So, agonists, the ones we now use are pramipexole and ropinirole, which are available generically, and they are called Mirapex and Requip originally, the brand names. Now we have the Nupro patch, which is rotigotine patch, and we even have the subcutaneously injected dopamine agonist, which is apomorphine, which is as a rescue drug. But the main problem with agonists is that it causes some side effects which are more and worse than levodopa. It causes more leg edema, it causes low blood pressure, it causes drowsiness and sleep attacks, it causes more hallucinations and psychosis compared to levodopa. It also causes impulse control disorder. The most common one being pathological gambling, disinhibited behaviors such as compulsive eating, hypersexuality, too much shopping, even examples of road rage and weird behaviors and things like that. I've seen also substance abuse. The prevalence of impulse control disorder in any tertiary care center using agonists can be as high as 15%. So something to monitor patients. And you have to make sure you also talk to the spouses, because patients themselves may not be able to tell you that they're behaving in such a way, or willing to tell you that they're behaving in such a way. So I've mentioned these names: pramipexole, Mirapex, ropinirole, Requip, the Nupro patch, the rotigotine, which is a newer one, still brand name and expensive. We use these drugs for both early disease and more advanced disease. It causes less dyskinesia than levodopa, but more side effects, which I mentioned in my previous slide. And people who have dyskinesia, the way you use these drugs is if you add the dopamine agonist, it allows you to reduce their levodopa dosage, thereby alleviating dyskinesias, but still maintaining their motor function without making them feel slower or shakier or stiffer. And you can convert people from one dopamine agonist to another. The dose conversion is around 1 to 4 for pramipexole to ropinirole, and equal between ropinirole and the Nupro patch. So they're available generically now. And even the Mirapex ER and Requip XL are available. These are once daily long-acting forms available in a generic form now. Apomorphine injections are basically like insulin subcutaneous injections, which are for a rapid onset rescue. They start to work within minutes, but they only last about 90 minutes, just to rescue a patient from a severe off episode. They have to actually come into the clinic for their first injection for you to actually make sure that they don't faint, because it does lower blood pressure. They get acute nausea from it. They have to actually be pre-medicated for 3 days with Tygan to prevent nausea from their first injection in the clinic. So it's a complicated, long process. So moving on to MAO-B inhibitors. These are drugs that block the breakdown of dopamine inside the brain. Selegiline is the older one. Azilect is the newer one. It'll become generic next year, I think. It's still brand name and expensive. Zolpidem is a new formulation of selegiline, which breaks up in your mouth and actually gets absorbed through your oral mucosa for a quick onset. And this is still brand name. But we normally use still selegiline, old generic, and Azilect these days. We hardly ever use Zolpidem. But these are basically enhancers of dopamine. We can use them both in early disease and in more advanced disease as adjunct therapy. In general, MAO-B inhibitors are less potent than dopamine agonists, which in turn are less potent than carbidopa-levodopa. And frequently, when you start people on medications for Parkinson's, you begin with an MAO-B inhibitor as the first layer of drug, then you add on a dopamine agonist, especially in a young, healthy person, and then you add on carbidopa-levodopa as a third-line drug. In older people who are more frail, I go straight to carbidopa-levodopa because you're trying to get them better, and you don't want to start them on agonists because they cause more hallucinations and psychosis, and they're not good for people who have mild dementia. Imantidine is mostly used to help alleviate levodopa-induced dyskinesia nowadays. It is also used in some people like to use it in early Parkinson's disease because it has some anti-Parkinson efficacy. It's been around for a long time. It's an old antiviral drug that they used in Parkinson patients back in the 1960s. They realized it helps their Parkinson's a little bit. But when levodopa came along, it basically made imantidine fade away. But it's actually quite effective in reducing levodopa-induced dyskinesias, those fidgety, squirmy chorea movements. So now that's the usual scenario where I use imantidine. In terms of dementia, the risk of dementia in Parkinson's is about 4 times, sometimes even more than the average population. So Parkinson's is not just a movement disorder. It does make people demented because the Lewy body pathology of Parkinson's is quite widespread. It does involve various parts of the brain, including the cognition. So some of the drugs that we use for Alzheimer's disease are also being used for Parkinson's dementia. The one that has been studied the most is Exelon, rivastigmine, which is FDA approved for actual dementia in Parkinson's disease. These other two are not FDA approved, but we still use them frequently, especially Aricept and donepezil. They don't do marvelous, work. They're not miraculous in any way, but they do help a little bit. So we do use these drugs, especially the Exelon, and both in oral form and Exelon patch for Parkinson's dementia. And sometimes we use memantine as an add-on drug on top of one of these 3 drugs. We don't use, obviously, these in combination because we only use one from each class. So we might use rivastigmine together with memantine as an add-on drug in dementia for Parkinson's, the way we use for Alzheimer's disease. In terms of psychosis, people with Parkinson's are more prone to having hallucinations, will-formed hallucinations, and paranoid behavior. But fortunately, even low-dose antipsychotics like quetiapine are fairly effective in reducing hallucinations in those people. The first thing I would do if somebody hallucinates with Parkinson's is to stop their agonist. You stop the agonist because they are more likely to cause hallucinations. If that doesn't work, then you can add quetiapine, which is among the safer drugs for Parkinson's because it has one of the least dopamine blocking activities among the atypical neuroleptics. Clozapine is the other one, but for clozapine you obviously have to monitor, because it can cause bone marrow suppression, you have to monitor their CBCs every week for first 6 months and then every 2 weeks thereafter. So it's hardly ever used for that reason. But low-dose Seroquel is commonly used for Parkinson's disease. But as I said, the key thing is to see if you can actually reduce the dopamine agonist dose or stop it altogether, or even reduce the dose of carbidopa, levodopa, because even levodopa is psychotogenic. And then if you have to, then you can use low-dose quetiapine to suppress hallucinations and paranoid delusions. So REM behavior disorder is actually very common in Parkinson's. It's the acting out of your dreams. And it can actually precede Parkinson motor symptoms and signs by a few years, especially in men. And the best initial option would be melatonin, over-the-counter medication melatonin. And if that doesn't work, then we can add low-dose clonazepam, which is very effective for REM behavior disorder. So in 2015, last year, 2 new drugs came out for Parkinson's. They're both new variations of carbidopa, levodopa. Ritari is a new version, and sort of new and improved, much more expensive version of carbidopa, levodopa, which is meant to be taken just 3 times a day, has a longer half-life. It's made up of these little tiny beads that get absorbed at various durations after you ingest a pill, and it breaks up. And it travels at different speeds. So the first dose gets absorbed, the first batch gets absorbed right away, so you get sort of a quick on within an hour. But the last ones are supposed to last up to 5 or 6 hours. So it is meant for people who are taking their medications very frequently, and they want to reduce the frequency down to 3 times a day, let's say, so that they can have a better lifestyle. So it's the same drug. It's still levodopa, except it just lasts longer. And duodopa, which is this intestinal gel, you have to wear a pump around your belt, and you have to have a PEG tube in. You have to actually have an intestinal tube that delivers a continuous gel form of carbidopa, levodopa into your small intestine for a more continuous absorption. It's for those who have a lot of fluctuations and wearing off and dyskinesias, who would rather not undergo brain surgery and are willing to take another invasive route by having a tube in their stomach and having the levodopa delivered to them more continuously. So these 2 drugs just came out last year. In terms of deep brain stimulation surgery, abbreviated here DBS, the main 2 targets for Parkinson's are subthalamic nucleus and the globus pallidus internus, STN and GPI for short. These are targets which are hyperactive in the setting of Parkinson's, so by putting electrodes in them, you're actually making them less active. By zapping them at very high frequency, you're making these targets less active, thereby alleviating the signs of Parkinson's to some degree. They're not, again, miraculous, but tremor is improved quite a bit, and so is rigidity and bradykinesia to some degree. They do allow for some medication dose reduction. We at the VA did a multi-center randomized study. This was the biggest one of its kind in the world, comparing GPI and STN, and they kind of tied in terms of efficacy. STN was more effective at reducing medication doses, and GPI did better in terms of having less side effects cognitively. Another paper just published a few months ago from Europe clearly says STN is better than GPI in terms of outcome. In terms of motor outcome, in terms of the amount of medication dose reduction, and the degree to which it helps, let's say, tremor, rigidity, and bradykinesia. So, and most people still do STN as a target of choice for DBS, and that's also what I mostly prefer. Who's a candidate for DBS? These are folks who have advanced Parkinson's usually, but they're non-demented. They tend to be younger and healthier without too many comorbid conditions. They don't have too many psychiatric problems. They can handle having the surgery. They can handle coming to the clinic frequently, post-operatively for DBS programming. Ideally, they should not be anticoagulated, but even if they are, we can still do them. And this last one is very important. They need to know what they're getting into. What they expect should be realistic. If they expect too much, they're going to be disappointed. One thing I keep telling them is that if your gait and balance are really, really bad, that's not going to get better with DBS surgery. It is meant for those who have several hours of disabling off time per day, or several hours of disabling dyskinesias per day. They want to have their medication doses reduced, and they want to have more off time, and or less severe. I mean, more on time and less severe off time. Those are the candidates. So if anybody tells them that your gait and balance, even on medication, is going to get better with DBS, that would be false advertisement. I keep telling them that you need to know what you're getting into in terms of DBS surgery. So I'm going to go on and go over some cases I've seen in clinic over the years, starting with the first one. This is a case of a woman in her mid-70s who comes in with a few months of left upper extremity tremor. And she has some comorbid conditions. She has some heart disease and COPD and osteoarthritis. She's a little obese, and on exam she had the typical reduced mask facies of a Parkinson patient. She had a left upper extremity resting tremor, a bilateral cogwheel rigidity, left more than right. So again, the same asymmetry you see in a tremor, you also see the same thing with bradykinesia and rigidity. So she is textbook classic Parkinson's, basically. She comes into your clinic and has textbook classic early Parkinson's, except she's a little older than the average person who comes in with this problem. And I put her on carbidopa, levodopa, 50/20 half a tablet 4 times a day. And she did improve. It did improve her symptoms, again, thereby proving that she has Parkinson's the way we know Parkinson's, but she became nauseated from it. So I told her, you can take this medication with food instead of empty stomach. I prefer you do it empty stomach, but if you can't handle it, take it with food. As long as the food is not protein rich, it should be absorbed. So that's what she did. And it worked out okay for her. So again, in older people who have a lot of other stuff going on, I tend not to begin MAOB inhibitors or agonists. I go straight to Samii. I go straight to carbidopa, levodopa. And I have them try to take it away from food if they can. But if they get nausea, you can actually take it with some carbohydrate-rich foods, and it'll still be absorbed. So that's lesson learned from the first case. Here's a case of a lady who was young. She was only 46 when she came to us, and she came to Harborview. I saw her with one of our neurosurgeons, and who's left us now for Swedish. And she was sent to him because of left hemidystonia. She had a crooked-looking foot and ankle, and she was a little stiff on one side, on the left side. And she had this very tortuous, on MRI, very tortuous left vertebral artery that was indenting the brainstem. We see this in normal people a lot, where they have a tortuous vessel that squeezes the brainstem, but they walk around fine, they have nothing wrong with them, and they're normal. So the neurosurgeon felt that the vessel was not the cause of her problem because she had other issues going on, so he referred the patient to me. And when I examined her, I thought she had Parkinson features on exam. I thought she had some rigidity and some bradykinesia, and she obviously had a foot dystonia, which can be a presenting sign in about 1% of patients. So remember, when people show up with dystonia, especially in the foot, that can be a rare presenting sign of Parkinson's, and that was the case in her. But when you examined her, she did have this left-sided rigidity and bradykinesia. I didn't have much resting tremor, and I put her on a dopamine agonist, and then she got better. And the dystonia got better, and all the other symptoms, including her finger tapping and her bradykinesia, got better. So another example of young onset Parkinson's presenting in a funny fashion. So lessons learned from this one: tortuous vessels are common. We see this, especially in the brainstem with the vertebrals and basilar vessels. It doesn't mean you have to do something about them. Most of the time, they're asymptomatic in folks. In her case, dystonia can be a presenting early sign of Parkinson's, and in young healthy people, I begin treatment with either dopamine agonists or MAOB inhibitors. In her case, I chose to put on an agonist, and she did well. Agonists tend to be more potent, as I said, than MAOB inhibitors, but you can go either way. Okay, and we do rely on improvement with agonists or MAOB inhibitors or levodopa to define Parkinson's disease. So this is a case of a 71-year-old lady with 4 months of left arm tremor, only when she was lifting stuff, and she was clumsy in the left arm. She had tremor at rest as well as with action. So she had tremor when she was holding something, and she had cogwheeling at the left wrist and the left elbow, and she had reduced left arm swing, which is common in early Parkinson's because of shoulder rigidity. In her case, she was put on carbidopa, levodopa, but she had no response to it. And when she tried to go higher on the dose to see if you can actually get a response from the higher dose of carbidopa, levodopa, she got nausea from it. She even had started taking it with food, but she still had nausea from it. So she could even take it with food that was not protein rich. So when we stopped the sentiment, things got worse. So that means she wasn't noticing much improvement when she was inching up the dose, but when she stopped it quickly, she actually got worse, again proving that she does have levodopa responsive Parkinson's the way we know Parkinson's. When she resumed taking Sinemet, this time with Lodocin, which is just extra carbidopa. Remember I showed you that diagram of what carbidopa does. Carbidopa blocks levodopa conversion into dopamine in your serum so that more levodopa gets across the blood-brain barrier to become dopamine inside the brain, where you want it to become dopamine. And that's what carbidopa does. Sometimes the carbidopa in carbidopa levodopa is not enough to block the peripheral dopa decarboxylase, so you have to add a little extra Lodocin to the patient so that the patient in this case did well without any nausea, and the dose was able to be increased to 5,200 4 times a day, and she felt better. So, lesson learned here. Action tremor may accompany resting tremor. We always think about action tremor as that seen in essential tremor, but you can see action tremor with Parkinson's. It doesn't mean you can actually have both. There are people who actually think you can have essential tremor, and that changes the risk of getting Parkinson's later on in life, but they're very common diseases. They're both common. If you think of Parkinson's as being 1% over age 60 and essential tremor as being 5%, they're bound to happen in the same patient. So you will see that, and I have more examples of that to show. Some people need a high dose of levodopa to get a response. So sometimes the absorption is a problem, and I suggest that you at least try to push the doses up to 800 to 1,000 milligrams of levodopa, especially in the immediate release formulation, which is better absorbed, before you give up and say it doesn't work in this patient. And sometimes inching up the dose gradually doesn't give you the answer. So when I push the doses up high, let's say to 2 tablets of 25-100 4 times a day or 5 times a day, I say stop it cold turkey. So sudden cessation of the anti-Parkinson drugs sometimes gives you the answer. They get worse in the ensuing days to a week or two, and it tells you that, hey, this drug was working in these people when they were on it. Now that you stopped it, they feel worse, and there's the answer. Levodopa responsive Parkinson's. And last lesson here, Lodocin does give you extra carbidopa in case you need it to help the nausea from levodopa-induced conversion to dopamine. Case 4. This is a retired UW professor. He used to teach sociology here many, many years ago. And he presented with essential tremor that he has had all his life since he was a young man. He used to have essential tremor when he used to get nervous and when he was tanked up on caffeine. But then he presented with a resting tremor on top of the essential tremor. As I said, there are people, I am not one of them, but there are people who say that essential tremor does increase your chance of getting Parkinson's disease later on in life by about 2.5 fold. Okay? I don't fully understand the data, so I still think that the occurrence is by chance, but there are people who disagree with that. Anyways, in this case, he began having a right arm tremor, resting tremor on top of the essential tremor for about a year. And then he felt this quivering in his body. He was anxious and he was depressed for a few years, and he also had palpitations. On exam, he had resting tremor on the right with cogwheel rigidity, typical of what you see in Parkinson's. His facial expression was reduced, his gait was slow, and he had trouble with small handwriting, micrographia, because he was right-handed. He also had trouble riding his bicycle to UW. So one of my colleagues put him on carbidopa, levodopa 25-100, and the dose was ramped up to 2 tablets 3 times a day, which is a reasonable dose. And he didn't get any better. Again, we stopped the medication cold turkey. He did not get worse. Again, that points to the fact that maybe he doesn't have Parkinson's, or else he would be better. Turns out he was taking large amounts of protein in the form of meat and dairy product with each dose of Cinnamate. He was not taking it empty stomach. So this time I had him try a different kind of Cinnamate, a higher dose, and I told him to take it 1 hour before meals or 2 hours after meals, especially if that meal is protein rich for better absorption. And he had significant improvement, and he began riding his bicycle to UW again. Lessons learned from this case. Essential tremor and Parkinson's can coexist in the same person because they're both quite common. Some people need a much higher dose of anti-Parkinson drugs just to get a response initially. Remember the protein interaction and have the patients take it as much away from food as possible. So I suggest 1 hour before meals or 2 hours after meals. Next one. A young man with congenital hypoparathyroidism, so he had all kinds of calcium derangements in most of his life, and he had a short stature, and he was a little dysmorphic, and he had tremor most of his life. He was a piano teacher, and he started having both resting and action tremor and Parkinson features, left worse than right, and then I put him on Cinnamate. He got better at even low doses. And then he came to the ER at Harborview one day with severe neck dystonia. And he had torticollis when his drugs ran off, and he didn't get his medication refilled. So he developed a severe torticollis. He got 1 dose of Cinnamate in the ER, and his dystonia got better. So another example of how dystonia can be a presenting sign of Parkinson's, like that lady I went over, and how it can be a sign of an off period. So when the drugs were off, sometimes you become dystonic. You develop this abnormal posturing of your neck or your foot or your arm or your elbow or whatever. So in his case, he needed the higher dose of Cinnamate, and I added Mirapex because he was having endodose wearing off. Then he became psychotic. He became psychotic because of high dose pramipexole. He had paranoid delusions, he had hallucinations, and he had to be admitted to the inpatient psych service. Eventually, the Mirapex has to be stopped because he became psychotic. Quetiapine had to be added, and the dose had to be increased up to 200 milligrams daily. With the stoppage of the pramipexole and the going up on the quetiapine, his slowness, his Parkinson's disease got worse. So quetiapine had to be reduced, and we settled on carbidopa, levodopa, and quetiapine at a lower dose as a balance between too much bradykinesia and too much antipsychotics and stuff. So lessons from this case: dystonia can happen when you're off. Dopamine agonists can help alleviate wearing off because they have longer half-lives than levodopa does, but they also have a higher tendency to cause psychosis and hallucinations. Remember, the other side effects which are unique to agonists include leg edema, hallucinations and psychosis, impulse control disorder, okay, and drowsiness and sleep attacks. Those are things that happen with agonists, so you have to keep your eye on those. Quetiapine at low doses are effective for psychosis, but at higher doses can actually worsen Parkinson's motor symptoms. Things too. Next case, 47-year-old young onset Parkinson's transferring care to the UW, and he was on Cinnamate CR, 5,200 3 times daily, and regular Cinnamate 5 times daily at 3-hour intervals. So he's having enough wearing off that he's taking his medications very frequently. His main complaint again was end of dose wearing off. So I went up on the 5,200 to 1.5 tablets 4 times a day, and I told them to just use the regular Cinnamate if he wanted to for a jump start in the morning, and I added entacapone to prolong even the action of the Cinnamate CR, and that kind of worked. He had good results. So here, remember that when you switch from regular release to controlled release, the controlled release version, the levodopa in it is 30% less well absorbed. So you have to take that into account. Okay? And sometimes I use immediate release all day and controlled release at bedtime for overnight. Sometimes the opposite. Use controlled release daytime and the regular release just for a jump start in the morning. And that's what we did in him. And entacapone, being a COMT inhibitor, prolongs the duration of action of levodopa, so it helps alleviate end-of-dose wearing off even more. So here's one example of that. Entacapone makes your urine bright orange. So remember, if you put people on entacapone, tell them, because they're going to stain their underwear bright orange and they get all freaked out. So, case 7. 65-year-old lady with Parkinson's for 10 years, transferring here to UW. She had severe disabling dyskinesias, really very similar to Michael J. Fox when he's tanked up on levodopa. So she was on just regular release in the morning for a jump start. Then she was taking Cinemet CR, 2 tablets daily, so 1 and a half, not too much, but she was taking tolcapone, which really elevates levodopa levels. It's a very potent COMT inhibitor, plus Reclipse. All of these together were giving her dyskinesia. She was not a very big lady, so she's thin. First thing I did was stop the tolcapone so we don't have to draw liver enzymes on her every 6 weeks. And we didn't change the overall daily intake of Cinemet CR. We just divided it more evenly throughout the day. So instead of 1 half, I had her take half a tablet 4 times a day, and I did not change her regular release Cinemet. But I did go up on her ropinirole. So remember, drugs like agonists, they cause less dyskinesia compared to levodopa. So if you want to reduce levodopa, you want to reduce dyskinesias, you can reduce the levodopa intake. In this case, the levodopa intake was reduced because I stopped the Tasmar, because that enhances the dose of levodopa. But you compensate for that by adding an agonist or going up on the already present agonist. They tend to be less dyskinesiogenic. So in her case, she had less dyskinesias. She didn't have any worsening of her Parkinson's bradykinesia, and she didn't need to have any LFTs drawn anymore because the tolcapone Tasmar was stopped, so she didn't need any liver function monitoring. So lessons learned. Remember that tolcapone, if you hardly anybody is taking it these days, but if you ever see someone on it, you have to make sure you check their liver enzymes frequently. You can try to even out the way you deliver carbidopa, levodopa, sometimes just by spreading the doses more evenly throughout the day without changing the overall daily intake. You can actually help alleviate dyskinesias and wearing off, both of them. So that's one thing you can do. Agonists tend to last longer, they have longer half-lives, and they're less dyskinesiogenic, and they allow for a lower medication dose when it comes to levodopa. So these are the lessons learned from this case. Next one, a young man with a long Parkinson's history, so very young onset Parkinson's. He began having PD when he was in his late 30s, and he was taking very frequent dosing, up to 20 pills a day of this stuff, of the regular release one, every 90 minutes. And he was still having motor fluctuations, and he was saying that he was off more than 4 hours per day. And when he was on, he was dyskinetic. And in fact, he was using analgesics because the dyskinesias were painful. So he tried ropinirole. So this is one way to try to, again, reduce the dose of levodopa and dyskinesias, is to add an agonist and then try to reduce the Cinemet. In his case, it didn't work because it caused severe nausea and dizziness and sweating. And I switched him to Cinemet CR, but the absorption was unpredictable, and he had even worse off episodes. So that didn't work. So I added entacapone, and that allowed me to reduce the number of pills of levodopa from 20 down to 14. So in this case, again, entacapone prolongs the action of levodopa, and we were able to increase the interval between the doses from 90 minutes to over 2 hours with less wearing off and some dyskinesias. Then he ended up getting brain surgery. So he had DBS surgery in the subthalamic nucleus, which improved his symptoms dramatically, and he was able to reduce his carbidopa, levodopa, and entacapone down to just 4 times a day. So in his case, a dramatic improvement in his condition and much, much less dyskinesias. So in this case, DBS, young onset, very helpful. So lessons from this one: COMT inhibitors can help wearing off, but they can exacerbate dyskinesias because basically what they're doing is they're raising levodopa levels. Bilateral ST and DBS helps improve motor symptoms like tremor, rigidity, bradykinesia, and it can allow for medication dose reduction. In his case, that's what he had. But GPI is also good, and it can reduce dyskinesias tremendously. And whenever you see younger, healthier people who are non-demented and psychiatrically stable with severe fluctuations and dyskinesias, think DBS, because it can really be helpful in them. Here's a older man from Punjab, India, and he don't know exactly when he started having Parkinson's, because when he came to the US, he was already quite Parkinsonian, and he was very rigid, bradykinetic, and he was already having trouble with his balance. And he may have had dementia, I'm not sure, because he was illiterate even in his own language, and he didn't speak any English. So he was on regular Sinemet. We switched him to Sinemet CR, and the dose was increased, and he was improved. So again, levodopa-induced, levodopa responsive Parkinsonism, but he had other problems. He had severe esophageal strictures, and he had to be hospitalized, and GI had to go in and dilate his esophagus at Harborview, and a PICC tube was placed. And so when you put a PICC tube in, because you can't swallow or for other reasons, remember that you have to switch. When you switch from controlled release to regular release, you can make somebody toxic, or you have to take into account that the regular release is 30% better absorbed. So if you crush the CR, it also becomes regular release. So if you take the 5200 pills and you crush them, you're basically making a regular release, and it gets absorbed even more readily. So always take that into account. So if you have somebody post-op coming into you, and they have to have an NG tube, and you have to crush the Sinemet down the NG tube and give it down the NG tube, you have to make sure that you take into account the fact that the levodopa in the crushed form, in the regular release form, is 30% better absorbed. So in his case, he had side effects. He got nausea, some hypotension. All of these you get with Parkinson's. Hallucinations and dyskinesias. His nausea got better when we added Lodocin. We actually had to add Florinef to raise his blood pressure, but he got a rash from it. Then we had to add Midodrine to raise his blood pressure even more, because he was so hypotensive, and he got dyskinesia, so we had to reduce his Sinemet a little bit and added some pramipexole. Then he had hallucinations with pramipexole in the setting of having SIADH, because he was taking citalopram, which gives you SIADH and low sodium. So much happened to him. And the hallucinations persisted even after we stopped the agonist. So in his case, he had to be on quetiapine. Even low dose in his case worsened his motor symptoms. Some person in the ER thought of giving him Haldol, which made him really, really worse. So you don't want to give Haldol to a Parkinsonian, because it's a very potent D2 agonist, and it makes you much worse. And I think he got it so they could get a head CT on him. So we had to put him on clozapine as a last resort for his psychosis. And he did have less hallucinations, and his motor symptoms did not get a whole lot worse, but then we had to check his CBC every week for 6 months, and then every 2 weeks thereafter. So he's a very complicated Parkinson patient, and everything went wrong with him. All the drug side effects we mentioned happened to him. So we talked about the NG or PEG tube and crushing, and how you take into account the dose conversion between CR and regular release. Hypotension is common in Parkinson's. We can use Florinef, which is a mineral corticoid, or Midodrine. And now there's, as of a few months ago, there is this new drug that just came out it's called Northera, droxidopa, which is meant for blood pressure derangements in neurogenic orthostatic hypotension. Agonists are more likely to cause hallucinations, but they cause less dyskinesias. Anything that causes metabolic encephalopathy can make your hallucinations worse. PD patients are very sensitive to Haldol, so do not give them Haldol or risperidone or even Geodon or any of that stuff. We normally only use quetiapine or clozapine, okay, for Haldol, for patients with psychosis in the setting of Parkinson's disease. And I'm going to go over the last case here. This is a man who is 52. He began seeing when he was 52, but he had symptoms when he was 45, right-sided bradykinesia. Initially put on ropinirole, which caused some nausea and vomiting, then switched to Sinemet, and then entacapone was added, and then increased over the years to 5 times daily, and pramipexole was added. So he did better with one agonist versus the other. He was tried on Requip, didn't work, caused vomiting, but he did well even on high-dose Mirapex. Then he develops impulse control disorder, both gambling and hypersexuality. His wife was very distraught because he was downloading pornography and placing ads on singles websites, and so did not make his wife happy. So we actually had to, I lowered his Mirapex, it didn't do anything. I had to completely stop the pramipexole for the impulse discontrol to go away. Then he was under-medicated and felt very Parkinsonian, so we resorted to having him have DBS done. He had the bilateral STN stimulators placed, which really helped his motor symptoms. And then we settled on a combination of carbidopa, levodopa, and tachypone, which is basically Stalevo, after his DBS was done. And his daughter is a nurse, and she's very helpful in managing him. Now he has more advanced Parkinson's, but he still comes and sees us in clinic. So lessons learned from this one. Remember, so some people do better with one agonist versus the other. Just because he didn't do well with ropinirole doesn't mean he can't try the other agonist, let's say pramipexole. Impulse control problem, remember the 15% prevalence rate in tertiary care centers with agonists. It's not insignificant. And they include overeating, compulsive gambling, hypersexuality, shopping, etc. And you might have to stop the agonist completely before the impulse discontrol problem goes away. Always ask family members, because the patient may not be able or willing to tell you that they're having pathological gambling or hypersexuality or road rage or whatever. And again, we talked about DBS as helping motor symptoms in well-selected cases. In his case, he was young and relatively healthy, non-demented despite hallucinations, and he did well with it. So, and I think that's the end of my talk. 10 cases.
We already have a chat question, so I'll start with that one. It says, would the gentleman from Punjab do well now on duopa?
You know, people who use intestinal gel, usually they're non-demented patients. And so in his case, I had a feeling, I haven't seen this man in a long time. He may have passed away. I haven't seen him in many years. But my guess is probably not, because he was already demented. But I think that anybody who you're referring to DBS surgery, they should be told about this intestinal duodopa gel. Because it's less invasive than brain surgery. Many people choose not to because it's very labor intensive, has infection rates, the pig tube clogs. There are people who get peripheral neuropathy from it, which I didn't get into. And it's tough to maintain. And you have to have a little thing hooked onto your belt when you walk around pumping the gel in. So they opt sometimes for more invasive DBS surgery.
Thinking in terms of possibly either preventing or delaying the onset of Parkinson disease, I noticed that you began by referencing statistics from Western Europe and North America. Is there a possibility that one or more of the spices used in Asia, Eastern Europe, and South America may either prevent or delay the onset of Parkinson disease?
It's possible. We don't have great data. There's all kinds of dietary studies, including some that I've published with my Canadian colleagues, that suggest, let's say, dietary use of vitamin E with nuts may reduce the risk of Parkinson's. There was one paper published by our center here, I was not a co-author on that one, that bell peppers, red peppers, actually might reduce the risk of Parkinson's. We don't know that, but it's very tough to duplicate those. We do know certain things. Because this talk is mostly focused on treatment, I didn't want to get into this, but I'll get into this. So head injury, I think, is a risk factor for Parkinson's. We've done a study looking at all the previously published studies and meta-analyzed it, and even a one-time concussion does raise the risk of Parkinson's. Well water drinking, it does raise the risk of Parkinson's by a few percentage points. And living on farms where pesticides are used. So well water drinking, because pesticides are thought to seep into the well water, do increase the chance of getting Parkinson's. So living in rural areas does have an increased risk in industrialized nations. It may be the opposite in developing nations like China, where urban living may actually have a higher risk. Smoking is protective. Study after study after study suggests that tobacco use does reduce the chance of Parkinson's by about 10, 15, 20%. And if you have a population where you actually don't see that, then maybe something wrong with your population, because that's something that is fairly reproducible. In terms of turmeric and all that stuff, I don't know. There's all kinds of theories about antioxidants, such as turmeric, may be useful, but we don't have great data. The same is true for CoQ10. There was one study published in CoQ10 about 12 years ago saying it may reduce the risk of getting Parkinson's, but another bigger study didn't find that, so now we don't recommend it as a supplement. We are studying glutathione intranasally as a intranasal delivery system because we think it may get into the brain better than intravenous, obviously. So that is being looked at, but we have no definitive answers. So as far as I know, the answer to whether we have a definitive neuroprotective agent that reduces the risk of getting Parkinson's or reduces the progression of Parkinson's at the molecular level, the answer is no. We don't have such a thing. So you have your risk factors, well water drinking, maybe head injury, solvents, some other stuff, and you have the things that seem to be protective, including very high use of caffeine. So high dose caffeine intake and tobacco smoking reduce the risk of getting Parkinson's, but once you have it, they don't do anything for progression rate, as far as we know.
Do you prescribe?
Yeah. And the reason I quote the North American numbers is because we have data from them. This is the disease of aging. The major risk factor for Parkinson's is time, is aging. So people who may not live as long in developing countries where the life expectancy may be 60, 65, 70, they do have a lower rate of Parkinson's. And diagnosis is also an issue because people may not be diagnosed with Parkinson's. They may be diagnosed with essential tremor or just aging and things like that. So we don't have great data from many developing countries. But the data from developed nations point towards the percentage I just quoted. So,
okay.
Yeah.
Do you prescribe movement and or exercise with your medication regimens?
I don't prescribe it, but I put it in my instruction sheet when I hand it to the patient. I mean, yes, the answer is yes. So we do have data in humans and in animal models, in rodent models of Parkinson's, that exercise does reduce the rate of progression at the molecular level in the animal models and the physical level in human beings. So the answer is yes. There's all kinds of data on tandem stationary bicycling and this and that, and following motor scores over time and how people do much better when they exercise. Initially, we thought it was this exercise or that exercise. Now it's really anything. It doesn't have to be bicycling. It can be walking. It can be Tai Chi. We have data on a lot of stuff. So I usually tend to tell people to cross-train, not do the same thing over and over again. Do a little walking, do a little swimming, do a little bicycling, even tandem bicycling in the wintertime, stationary, recumbent bicycling with horizontally. I want to make sure that they're safe on the road. If they're unsteady, they should not be riding a bicycle. And doing the core exercises, especially for their belly and their backs. They're all helpful. And even light weights, light weightlifting. All of those are good for Parkinson's. And they should try to do something every day. It doesn't have to be long. It just has to be, if they can't do something for 30 minutes, divide it over 3 10-minute slots in a day. Just ride your bicycle stationary, 3 10-minute slots instead of 1 30-minute slot. So.
What was the name of the new hypotensive medication that you had mentioned?
Northera, N-O-R-T. I haven't used it. Droxidopa, I think is a generic name for it. It's used, it's supposedly, the claim to fame of it is that it is meant to raise your standing blood pressure without raising your supine blood pressure. So it's meant to help your orthostatic hypotension without giving you supine hypertension. So I would rather have people have high blood pressure than low blood pressure in Parkinson's. I was on the side of not lowering the blood pressure too much. So.
What is the youngest a person can exhibit symptoms?
I have seen a patient whose first symptom began at the age of 8. So yeah, she had a genetic kind of Parkinson's with a Parkin gene mutation, a juvenile onset recessive gene which affected her and her sister. She's now 51 It took her 10 years to be diagnosed in her late teens, and she ended up having brain surgery with DBS, and she's still ambulatory. And she has at least one child, if not two kids. Yeah. She's around 50.
And would someone like that get genetic counseling?
Yes, because she has two copies of one gene, Parkin gene, so she is able to pass on. It's not a common gene. Pass it on. So chances are her kids are going to be fine because you need two bad genes. Yes. So.
Interesting. Yeah. Are there non-medical treatments and/or supports that improve quality of life in these patients?
So the answer is yes. We have a big support group system here. We have our Washington State chapter of the APDA, the American PD Association. It's run out of an office we have in Queen Anne, and we have people who run it. And we try to take turn giving lectures to support group and patients and caregivers and things like that. And the logo of the APDA Washington State chapter is ease the burden and help find the cure or something like that. So easing the burden is a big part of it.
And are you aware of similar supports like in Alaska or Wyoming, some of the other
We
sites?
cover those areas actually.
Oh, okay.
Yeah, so the Washington State chapter covers those areas. We don't cover Oregon because they're pretty big themselves. They have good setup over there, but we do cover Idaho, Montana, Alaska. Yes.
And Providence Valdez asks something you just spoke about, which is there a genetic component with Parkinson's? Is there anything more you'd want to say about that?
So the younger the onset of Parkinson's, the more likely that genes play a role in Parkinson's. If you were to ask a person randomly on the street, if they have a first-degree family member with Parkinson's disease, 4% of the population answers yes to that question. If you were to ask that same question of a Parkinson patient, 15% answer yes to that question. So the answer is yes. There is a familial aggregation of Parkinson's, but most people with Parkinson's do not go on to have offspring with Parkinson's disease. The other issue is that people who have the same genes also grew up on the same farm. They drank the same well water, exposed to the same pesticides. So just because people of the same family have the same Parkinson's or the same disease doesn't mean it's genetic, because they also share the same environment as they grew up. So you have to separate those which are not easily separable. Mm-hmm. But the older the age of onset, the less likely that genes played a role, and the younger the age of onset, the more likely that genes do play a role.
How about mineral supplements? Does deficiency in any minerals have any bearing on developing Parkinson?
Not that I know of. Not that I know of. We know that vitamin D deficiency can make your Parkinson's look and feel worse. And obviously, vitamin B12 can give you neuropathy and all kinds of problems. But we don't have data on zinc and manganese and magnesium and things like that. Now, manganese toxicity, which is extremely rare, can actually make you look like you have Parkinson's. It gives you a Parkinson look-alike dystonic syndrome. So too much of a certain mineral, yes, can give problems. Yeah.
And how soon after diagnosis, how many years before dementia might show up in someone diagnosed maybe at 58?
It's very hard. It is nearly unpredictable. But there are variations of Parkinson's. So people who present with a tremor-predominant Parkinson's, they tend to do better. And they tend to have a slower progression, and they tend not to become demented so early. But patients who present with a rigid bradykinetic kind of Parkinson's, and they have an earlier postural instability and earlier gait disturbance, they tend to become demented earlier.
Do you see any statistics that Parkinson's skips generations?
Yes. I don't know the statistics by hand, but I see people whose grandparents have Parkinson's, but their parents do not. Yeah. I don't know. That probably has been studied. I just don't know the results of that study.
Could just be genes that are...
Yes. The most common autosomal dominant Parkinson's form that is not young onset is due to a gene abnormality called leucine repeat rich kinase 2. LRRK2. And it's about 1% of the people with general population of Parkinson patients have that gene, and about 5% of those with familial Parkinson's have that gene abnormality. And those with a familial history and Ashkenazi Jewish background, we're talking 30%. North African Arabs, 35-40%. So there's a population of patients who have that LRRK2 gene abnormality, but the penetrance of it is not 100%. So yes, it may skip a generation. But of all the autosomal dominant forms of Parkinson's, genetic, that is the most common cause, but the penetrance not being 100%, it can skip generations. Yeah.
So speaking of brain injuries, I know that tremors can accompany brain injuries. Does breaking the tremor cycle help delay or prevent the onset?
Not that I know of. So the tremor that one is talking about is probably action tremor, essential tremor. And you can get a post-traumatic cerebellar tremor, but that does not go on to become Parkinson's disease. So I don't think that, let's say somebody who has essential tremor, and you break the circuit of the tremor by putting electrodes in the thalamus to make the tremor go away on one side, is going to keep that person from getting Parkinson's later on in life by breaking that circuit.
And is there any relation to the microbiome gut flora balances and risk of Parkinson's?
I don't know that. I don't know that. We know. So the underlying pathological finding of Parkinson's disease is alpha-synuclein aggregation within different parts of the brain. So for all of these symptoms, the non-motor signs of Parkinson's we talked about, the REM behavior disorder, the depression, the constipation, the loss of sense of smell, the dysautonomia. We have anatomic substrates with alpha-synuclein pathology present in those parts of the brain, including the part of the brain that controls the sense of smell, the reticular formation that controls sleep, the midline alpha nuclei that controls serotonin, depression, basically, and the centers that are noradrenergic, the locus ceruleus has alpha-synuclein pathology. Now we know that the gut has alpha-synuclein pathology. So if you do colonoscopy, we all have to get colonoscopies after age 50. I had mine too. If you do a biopsy of the colon wall of a patient with Parkinson's, you are more likely to see alpha-synuclein pathology in that biopsy compared to age-matched controls undergoing routine colonoscopy. So the nerve endings that supply the gut or the bladder or the heart have alpha-synuclein pathology in them. As to whether that's change in gut transits and the fact that it causes constipation and gastroparesis even 5 or 10 years before you come down with Parkinson's disease, changes the gut flora, I don't know. So, yeah. But we know that that is part of Parkinson's. Having a slow transit time and constipation, sometimes decades preceding the onset of Parkinson's, is part of Parkinson's, basically.
So this is just a clarification about the question about brain injuries and tremor. The person says the brain injury tremor was a leg tremor associated with a certain foot position. I used to be able to control it, but I can't even get the tremors to start anymore. The brain injury was 45 plus years ago. I don't know if you want to add anything more to that.
So that may be, is there a arm tremor on the same side that there's a leg tremor? I don't know. So if there is one, so the the most common, I mean, if I were to guess the kind of tremor, it would be probably a post-traumatic Holmes tremor. It was described by a physician called Gordon Holmes about 110 years ago. And it's a action tremor that comes out. It's an irregular high amplitude tremor. We have actually reported the case of that after a brainstem hemorrhage, non-traumatic though, with leg tremor being being the site for the Holmes tremor. So brain injuries can cause tremor usually when they cause damage to a circuit between the thalamus, the red nucleus, the dentate nucleus of the cerebellum, and the inferior olivary nucleus, the molar red triangle. So if there's visible damage to a certain part of the brain or brainstem from the head injury, that may be the answer, but that is unrelated to Parkinson's. That has nothing to do with Parkinson's. That's a different disorder than for Parkinson's disease.
So here's a good question. At what point would you suggest they quit driving? I have a friend I'm concerned about.
So that is a very, very difficult question. And the way I answer that question is I ask the patient's family members who are with the patient, and I ask them, if you had grandchildren, would you allow this person to drive your grandkids to and from school? If the answer to that question is no, I tell them no drive anymore. I don't know how else. I'm not there to judge them when they're driving. There are devices and simulating machines. There's a guy in Iowa. His name is Ergun Uch. UC is the last name. Lots of publications on this topic. That the ability to multitask and put your visual space together when you're driving is messed up even in early Parkinson's disease. It's not normal. In more advanced disease, it's even more abnormal. One of the early things that goes bad in Parkinson's disease, again, one of the non-motor parts of Parkinson's, is that they have this inability to put the whole picture together. So we call that asimultagnosia. That is, the inability to put the entire picture simultaneously together. You see different parts, different stimuli coming at you from different angles, but you can't put the whole visual picture together. You're not demented. Your reaction time is slow because of Parkinson's, because you have bradykinesia. And you have trouble with multitasking. You have trouble with looking at the entire picture. So that already impairs your ability to respond to sudden stimuli coming at you from various directions. But in advanced Parkinson's, where you have motor fluctuations, you may be able to drive when your medication on, but when your drugs wear off, you may not be able to drive. And if it's unpredictable, you should not drive, because you don't know when these drugs will wear off, and you're going to be more shaky, more bradykinetic, and stiffer, and you can't drive anymore, and your reaction time is all messed up. So you have to increase your distance. You should not drive at night. You should not drive in, icy or wet roads. And it just keeps getting more and more limited. Not drive on freeways. And they say, I only drive to the store and back. I said, okay, but if your family member, again, do not want you to drive your grandkids to and from school, you should stop driving. Driving evaluations by OT are $1,200. They are not covered by insurance, and they get stuck. They frequently have to have driving evaluations annually by the DMV if they're really that bad, and then they can do that. So normally they do it when they're on so that they pass the exam, but what happens when the drugs wear off? You don't know. So I don't know. I mean, those are very tough questions. We have answers for epilepsy. You have a seizure, you don't drive for 6 months in the state of Washington. But we don't have great answers for Alzheimer's or Parkinson's disease.
But we've got a talk coming up soon on driving.
Okay,
so
good.
Should be interesting. Should these folks be drinking? Same friend I'm concerned about who drank while we were out to dinner.
Yeah. So last spring in our Pathfinder, which is our quarterly journal for the APDA Washington State chapter, which I run, and I had to write an article on drinking and cannabis use for Parkinson's. So the data on cannabis is iffy. It does help. It does help tremor a little bit and levodopa-induced dyskinesias to some degree, but we don't have good studies to show that cannabis is helpful. It does reduce anxiety, and some people use it to sleep better at nighttime. But it does worsen your cognition. It worsens your ability to drive a car. That's my concern. Drinking, the same thing. So one alcoholic beverage can really mess up your balance if you're already having trouble with postural instability. And it can make you drowsier when you're trying to drive. So even one beverage with dopamine agonists can really make you drowsy. So those are the big concerns. Gait instability, falling, and being able to drive even with a lot less alcohol that would make a regular person of a certain weight non-toxic. Those are the two things that I worry about. So my answer is preferably not, but if they don't have any gait instability or postural instability, they can drink in moderation, no more than one drink with dinner.
How long do the Parkinsonian medications continue to be effective?
I think forever. And the reason I say that is because the idea that these drugs only work for 5 years, 10 years, 15 years, goes back to the development of wearing off with levodopa. So almost everybody after 10 years of levodopa monotherapy gets fluctuations. Now that we have so many drugs in our arsenal, we can make these drugs last a little longer. And I have people who've had Parkinson's for 40 years now. 40 years. I have a patient who was diagnosed in 1976 at Georgetown University. And I saw him in 1993 at the NIH when I was a fellow. He moved to Seattle when I moved to Seattle, and he's now my patient. So I've known him for 25 years now, 23 years. And he already had PD for like 15 years when I knew him. And he still has levodopa-responsive Parkinson's. So even in advanced Parkinson's, we've had people who have had the disease for 25, 30 years. And when you stop their medication, they get worse. When you go up on the dose, they don't get better. But when they miss a dose or 2 or 3, they get worse. Still telling you that there is some levodopa-responsive component to their Parkinsonism, that there is a little bit of responsiveness after all these years, in that when they stop the medication, they get worse. So it tells me that there is still a little bit of those substantial nigrate cells left in order to pick up the levodopa, make it into dopamine in those nerve terminals, and release it so it can bind to the next line neuron down the striatum. So I think that these drugs in true Parkinson's, they still work even after decades of Parkinson's, because when you miss it, you do get worse. And you stop it, your symptoms do get worse.
So I think you kind of answered this question, but it's being asked again. So how long does someone have Parkinson's before dementia may show up?
I don't know. As I said, the rigid bradykinetic kind tends to cause dementia earlier. So, and some people never get dementia. As I said, this person with 40 years of Parkinson's is not demented. I have people who are non-demented after 2 decades, and I have people who are demented after 8 years. So the rate of progression of motor symptoms may be a predictor of how likely they are to become demented, especially bradykinesia and postural instability. I think those are the two key things that predict dementia. As I said, tremor-predominant Parkinson's patients tend to do better. They have a slow, if the tremor is the main issue they have, without much bradykinesia, without much gait disturbance, they tend to become less demented over time.
And have you ever seen someone grow out of Parkinson's?
I have not. It's not a reversible disease, and they were misdiagnosed. We have people who were misdiagnosed, and including myself. So this is a question that comes up. Every time you see someone, you have to think, does the person have Parkinson's disease? And if they don't get any worse after 10 years and they look the same, and you still have on levodopa, you say, well, maybe I should stop the levodopa to see if they get worse. If they don't, they may not have had Parkinson's to begin with. You may have misdiagnosed. Yeah.
Okay, well, I think that's all the questions on here, but are there questions here in the room?
I have a couple of them. Do any of those classes of medications that you discussed do anything other than the motor, affect the motor aspect?
So there are data on these drugs
Can you
helping
repeat the
mood.
question?
So the question is, do they help anything else but the motor symptoms? The answer is yes, because dopamine is implicated in apathy, the deficiency of it, in depression. So there's in fact one study with Mirapex in non-Parkinson patients for depression, which was positive. So these drugs may be antidepressants. Selegiline is an antidepressant. It's actually FDA approved for depression. They don't use it as much in psychiatry, but MAO inhibitors are antidepressants in a way. So the answer is yes, they can be used for mood disorder or Parkinson's, for depression, and there are certain data to suggest that they may actually help REM behavior disorder as well. Yeah, they may help RBD at nighttime. Yeah, it can go either way. I've seen people whose RBDs get better with Mirapex and get worse with Mirapex because they get vivid dreams and all that stuff. Yeah. Yes.
Does DBS affect the trajectory of the disease at all, or?
I don't know. I don't think so. I think
Repeat
it
the
puts
question.
it. So the question is, does DBS change the trajectory of the disease? It may. The reason I say that is from even levodopa, because before levodopa in the 1950s, people with Parkinson's would die after 10 years. So levodopa changed the trajectory at the physical level of Parkinson's in that they lived twice as much, 20 years. So by the 1970s and 80s, people with Parkinson's were living about twice as long as they were earlier, a decade or two earlier, because of levodopa. So your question as to whether intervention, whether medical or surgical, changes the trajectory of Parkinson's, at the physical level, yes. At the what you see level, yes. It probably makes people do better. They exercise more, they fall less, they break fewer hips probably, and they may feel better about themselves, so they may stay mentally and socially more active, which is good for them. At the molecular level, we don't have any data that medications or surgery changes the rate at which these substantia nigra pars compacta cells are being lost over time. So we have no way of measuring it. We have no way of measuring, we have no biomarker to measure progression of disease at the molecular cellular level, to look at alpha-synuclein pathology and the deposition of alpha-synuclein in different parts of the brain and nervous system. So we don't know. At the physical level, probably it does make a dent in the disease and makes you look and feel better, so you do things more. And I think of Parkinson's, especially in early Parkinson's, as a use it to lose it kind of thing. We have data to suggest that if you delay treatment, people do worse over time. We have data from levodopa, from rasagiline, from selegiline, all these drug studies that if you delay treatment, people tend to do worse. And it may simply be that if you leave people untreated, they don't do as well. If you help them move better, if you help them exercise more, if you help them speak louder, if you help them stand up taller, if you help them work longer, you may change the course of the disease, at least at the physical level.
You spoke about how you don't have markers, but I thought you showed a scan of those commas and how they changed.
So the DAT scan is a fairly good detector of abnormality in the untreated Parkinson's brain. But it's not a very good marker for progression of disease once you have it. When you start carbidopa, levodopa, it changes the scan. It's not a very good biomarker for progression of disease, to be honest with you. It's a good good test of detecting Parkinson's disease and differentiating it from normality and from essential tremor. But with serial SPECT scans, that by itself is not a very good detector, or at least a biomarker for progression of disease over time. You're only looking at the dopamine pathway. So we're looking at the scan only looks at the pathway between substantia nigra pars compacta and the putamen and the caudate, looking at one marker, which is the dopamine transport protein. There are other ways of trying to look at disease using different ligands. So there are PET studies looking at 3 or 4 different ligands at various parts along that pathway, using fluorodopa PET, using tetrabenazine, using methylphenidate, which are other markers looking at 3 different parts of that pathway. Together, it may be more useful to use multiple, but it's not really easy to use in regular patients routinely to follow the disease. And still, you're looking at the dopamine pathway. You're not looking at alpha-synuclein pathology in the brainstem, in the cortex, in olfactory apparatus, in your spinal cord, in your gut, your heart, your bladder. So you cannot really, unless you have a let's say alpha-synuclein binding ligand that you can actually PET the entire body looking for this marker of disease, if you want to call that a marker of disease. We don't have a marker of disease progression that we can use reliably to follow the disease at the molecular level. So, yes.
So you had kind of talked about like they exhibit these symptoms. Kind of your trial is putting them on something like Cinnamate and seeing if they respond. Is there anything that Cinnamate could exacerbate, or any kind of concern that you would think of before you would do that trial?
Yeah, side effects are dizziness. It can cause drowsiness. It can cause nausea. All of those things. There are people who just don't like Cinnamate. They hate it. They can't stand it. Even low doses, it cause side effects in some people. They just don't want to try it. Some people get better with Cinnamate, but they just don't want to be on it because they have side effects from it. So some people do get worse.
Any kind of paradoxical effect, though?
There are people who say my tremor is worse. I don't know why that is, but anxiety can make Parkinson's tremor worse. So anticipatory nausea can give you anxiety, which in turn can make your tremor worse. So yes, it can cause a paradoxical effect. Yeah.
So working in hospice, we sometimes pull people off meds like this. How would you suggest a taper, or how would you suggest taking them off?
So hospice is a tricky situation because you're trying to make people comfortable. Unmedicating or under-medicating Parkinson patients is very uncomfortable because it can cause rigidity and bradykinesia, and it can be and tremor, which can be very uncomfortable. So the answer is no. In hospice situations, they usually stay on carbidopa, levodopa. Yeah, we don't stop the carbidopa, levodopa because it's very uncomfortable. If they can't swallow, then that's a different story. But most people can swallow till the end, because you can crush the regular release carbidopa, levodopa, give it to them in applesauce. Not yogurt. Yogurt has protein in it. But applesauce, yeah. You can give it to them and they can swallow this stuff. Yeah. Yes.
In case 4, you talked about that patient having palpitations.
Mm-hmm.
Is there any kind of, was that just
So
extra,
palpitations are more common with selegiline. Selegiline has amphetamine byproducts which can give you palpitations. I have seen a patient who came in with atrial fibrillation 2 years ago on selegiline. So that's a very rare complication, but well documented actually. So other medications, all of them can give you palpitations to some degree. Medications that let's say in that case was ropinirole, I think, but they gave palpitations. An agonist can give you that because it causes nausea and it can give you paratoxic anxiety. So I don't know. But the more common medication that can give you palpitations would be selegiline because it has mild amphetamine byproducts. Yeah.
thank you very much.
So,
Thank you very,
yeah,
very much.
Sure, no problem.